a very warm welcome to all of you and a good afternoon. It's nice to see some familiar faces. I can see Dr. Mohanty, who is much senior to me, who's a part of this session. Hello, ma'am. Good to see you. I'm sure you can share a lot of your
Hi.
experiences during the talk. And like mentioned, it's nice to be for the session to be interactive, especially at the 3 p.m. slot, which is perfect to sleep or probably watch a movie or read and not listen to a boring didactic lecture. So let's hope to make this interesting by both of us being interactive with each other, and so that we both also end up learning from each other. So if you have any thoughts, suggestions, or comments, please put it in the chat box during the talk. Also, I will be looking at the chat, but at the end also we will be able to discuss. And also, if you have anything which you haven't understood while I am talking, if you want me to go slow, please interrupt. Otherwise, it's no fun carrying on if I have not managed to communicate what I should be. So without wasting much time, let me share my screen and start the talk. As it was introduced to you before, this is something on respiratory palliative care, a topic very close to me because I have been a trained palliative care, a trained pulmonologist till I got myself trained into palliative care. And I think I've discovered a very different side to myself now that I'm practicing palliative care in non-cancer with a focus in respiratory medicine. So since this is your 12th session of this course, I'm sure a lot of you would have had a lot of understanding on the basics of palliative care. And today in the beginning, I'm just going to focus on why there is a need for respiratory palliative care. So before actually we talk about palliative care in any chronic illness, it's important to emphasize the need for it, in especially in our country. And as you all would have probably had a lot of time spent being a doctor, I'm not sure whether all of you realize that the amount of Indians, or the percentage of Indians affected by non-communicable diseases, which by the government of India is also called as NCD, which can also be termed as non-cancer diseases or non-malignant diseases. A large population of our country is affected by it. For example, lifestyle conditions like diabetes, dyslipidemia, hypertension, cardiac illnesses, stroke, as well as respiratory tract diseases, including tuberculosis. So if you see, add up the percentages, we add 1 million Indians to the list of cancer every year. But if you see the number of Indians affected by these other chronic life limiting conditions, they are close to 40 to 50% of Indians. Now, we also need to realize that all these non-cancer or non-malignant conditions are not curable. Unlike infections, these are only controllable. And there are certain conditions, say like cirrhosis, like CKD, or even interstitial lung disease, which are incurable at times, especially when you do not get the liver, renal, or the lung transplant done. So we do realize that a lot of Indians spend a lot of their lives being diabetics, being hypertensives, and in and out of illnesses and in and out of complications of these chronic illness. The reason this slide was important is because historically, palliative care was started for patients with advanced cancer. Somehow, over the generation, the myth still remains that cancer is the only condition that needs palliative care. And the one slide that should actually break that myth is this one, considering the number of Indians who suffer from the complications of chronic, incurable, progressive illnesses. This is just a graph to show that in India, the incidence of multi-drug resistant tuberculosis, totally drug resistant tuberculosis, and extremely drug resistant tuberculosis is rising. And it is a physician made problem. And but when patients are diagnosed with these problems, they require a very long haul of treatment, vocational, social, emotional, financial support, which is the ethos of palliative care. So there is no reason why complicated tuberculosis should not get palliative care. Similarly, the rise in incidence of COPD, which is chronic obstructive lung disease, especially in a country like India, where a lot of people are exposed to domestic indoor pollution, like chula cooking, like agarbatti, havans, dhoop, etc., in a poorly ventilated space. So we have a lot of people besides cigarette smoke, air pollution, domestic air pollution that results in COPD. And there is a recent study which has shown the increase in the number of interstitial lung disease, and the COVID pandemic has only added to those numbers. All of you in your sessions in the past would have seen this particular graph. Today, my area of interest is graph C, where any organ failure, this is the trajectory of the patient who has renal, nephro, cardiac, neuro, as well as respiratory chronic illness. So if you see this graph, if I can just show it to you, uh, it is important to realize that this patient probably gets diagnosed at the age of 60 to 65 and leads a life with dips and acute exacerbations, hospital admissions, and slowly this is the time of death. So if you see, compare, if you actually analyze this, a patient of COPD gets diagnosed at the age of 65. From there to his death, it could be in anything between 10 to 15 to 20 years. Our patients with chronic illnesses and organ failure lead a life of high symptom burden and for a prolonged period of time. Secondly, non-cancer conditions are not perceived as life-limiting, because if you diagnose a patient to have lung cancer, immediately in his mind it is how many days do I have to live. But if you diagnose a patient to have COPD or interstitial lung disease or say cirrhosis, congestive cardiac failure, the patient or the caregiver is not going to look at you the next minute and say, how many days am I going to live, doctor? Because it is not perceived to be life limiting. We need to realize that these conditions are, we whatever treatment we do are symptomatic treatment. We are not able to cure cirrhosis. We are not able to cure interstitial lung or the anatomical damage done by smoking. So what we need to realize, these patients also require the support and integration of palliative care, because hospital consultants see these patients only during the dips in the ICU or the hospital. What happens to these patients when they go home? Is a COPD patient able to walk? Is he able to talk? Is he able to self-care? Is he able to eat? Is he able to sleep? These things are not in the purview of hospital consultants because they are busy carrying other patients and looking after other patients. So this is where the integration of palliative care into every specialty is important, because conditions like dementia, conditions like Parkinson's, conditions like a stroke are prolonged for a long period of time, not only affecting the mental health of the patient, but mental, physical health also of the caregivers. And that is exactly, again, the ethos of palliative care, where we not only look after patients, but their caregivers. And our main aim is to address and alleviate suffering, acknowledge that, yes, there is a lot of suffering, and how we could be their partners during this difficult journey. Yes, everybody can argue by saying that we are not able to change the outcome. Surely we are not. We are only physicians, we are not God. At the same time, by being a support and a friend through this difficult journey, we can make that journey bearable for the patient and for the caregivers. And therefore, it is important to integrate it at the right time. Another way of looking at a chronic illness is comparing the patient of a chronic illness to falling off a skyscraper. This patient is deteriorating slowly, floor by floor. And what do? We need to realize the way the patient lands depends on the way he falls. So what does this mean? How can we translate it in palliative care language? So if you have noticed that the patient is deteriorating, it is our responsibility to have timely, sensitive, unhurried conversations so that the patient and the family have both the time and the inclination to process it, analyze it, and prepare themselves. So what does this mean? This means that if the patient is deteriorating, we have seen 100 patients of COPD. We have seen 100 patients of dementia. So whose onus is it to bring up this difficult dialogue with the patient and the caregiver and explain to them the natural course of their illness? It has to be the onus of the physician that this is what is going to happen. Now, the manner in which you say is also important. That is why communication skill is very, very important. The more you practice to talk well, the more effectively you will be able to communicate, and they will not run away from your clinic. So you need to time these conversations properly. You need to have a trained way of talking to them. And after telling them the bad news, you need to know how to support them with the multidisciplinary team of palliative care. So it's extremely important to integrate palliative care as early in the chronic illness trajectory and not wait till the patient is actively dying. So if you see this graph, this is where we want to be. We want to be in a situation where we are associated with the patient and the family early on in the disease. So we also get an opportunity to form a rapport. We are going to discuss difficult situations. For example, do you want to go to hospital? Do you want to go into ICU? Do you want to be artificially ventilated? These are difficult, sticky questions and dialogues to have with the patient and the family. And we therefore not just need time, we also need them, the patients and the caregivers, to be able to think about these things. It's very hard, very often. Today, I get called after the patient is in ICU and after the patient is ready to be put on ventilator. It's a very difficult situation then to enter the scene and take over, and the patient doesn't even know who I am. This way, the transition from curative care to palliative care is much difficult, because suddenly you have had a pulmonologist for 15 years and there enters a palliative care physician just before the patient is supposed to be ventilated. The family is emotionally so stressed and not interested to look at you at a new face. So the care has to be smoothly transitioned, and the only way we can do that is if we are integrated early on. Unfortunately, most hospital consultants feel that palliative care is giving up, that palliative care will make the family lose hope. How can I talk about palliative care? So, palliative care, please remember, is not based on diagnosis or prognosis. It is the need of the patient and the family. Some people cope well, some people do not cope well. And for the patients who do not cope well, they need that extra support, which busy hospital consultants are not able to offer. So it is important to integrate palliative care in situations where you need to form a rapport, where patient is more, demanding, he has more needs, because it takes all sorts to make this world. So the other important thing which very often hospital consultants ask is, when should we refer to palliative care? So the timing is very important. As a doctor, when you are seeing a patient, in your mind, in your OPD, if you just sit and think, will I be surprised if this patient is not alive in the next 1 year? If you will not be surprised, that is the time to start proactive palliative care. So this surprise question you can ask yourself. And there are two very good documents which are available online, which I'm sure Pallium India will share it with you. Blue Maple from Manipal, as well as the gold standard framework, which give indicators for referral for every chronic condition: renal, nephro, cardiac, dementia, MND, Parkinson's, as well as airway diseases. I have picked up the airway disease indicators, and if your patient fits into this criteria of any two of these referrals, that is when you need to refer to palliative care. And what are those criteria? Any two of the following listed on this slide, which is: one, age, obviously elderly age group with any two: multiple hospital admissions, ICU admissions, deterioration in the symptoms, like when the breathlessness assessment is grade 4 or grade 5, patient is on continuous nasal oxygen, patient has multiple comorbidities, and patient also has had a deterioration in lung function. So if your patient has had any two of these, that is the probability of him living for the next 12 months is low. And that's why you need to start proactive palliative care. Now, the point is, it's okay. I mean, we are not able to prognosticate exactly, unlike cancer. In cancer, so much research has been done, 5-year survival, 10-year survival indicators. We are not because in non-cancer conditions the course is unpredictable, the referral for palliative care becomes even less, because if it, oh, the patient has bounced back, so now how can I even think of, talking of palliative care? But please remember, the underlying condition is still incurable. The patient is going to deteriorate and the patient is only going to worsen his condition. Therefore, it is very important to talk to patients about and their family about preparing themselves for an emergency. So these are the two documents I was talking about. I request Pallium India to share it with the participants. Extremely clear, lucid reading documents makes your life very, very easy of when you should refer patients to palliative care. And enough research has been done, like I said before, because historically, cancer patients got palliative care. Even when you compare lung cancer with chronic lung diseases, we very often see that the lung cancer patients get palliative care, while the patients with COPD or interstitial lung disease don't get. The other sad thing we see is those patients with non-cancer conditions end up getting more aggressive treatment in the ICU, less symptoms documented, therefore less comfortable and poor quality of death and more aggressive CPR towards end of life. Because cancer patients get palliative care, they get dignity, respect, and comfort much more than those who die with non-cancer conditions. And what we have also realized is, even if we've admitted patients with acute exacerbation of COPD, a lot of them, 50% of these patients, are dead in the first 6 months. So are we justified in admitting these patients and subjecting them to life prolonging treatments? What should we be focusing on? Quality of life or quantity of life? Why should we make a patient survive, prolong his misery, when really we should be doing what is focused in his best interest? And this will happen only if we tell the patients, ask them their choice. Unless we get into the habit of asking the patients, what would you like to do? It is very difficult to achieve a good quality of life till death. Second thing, and the most important thing, is for the patient and the family to decide. He needs full information in a language that he or she understands. And that requires time, which busy hospital consultants are not able to spare, which palliative care specialists can do, and do it because they are in a multidisciplinary team. Because there's a nurse, there's a physiotherapist, there's a counselor, there's a social worker, there's a volunteer. So many people can divide and give attention to the patient and sort his very, very simple, basic questions. So it's important to realize that even if we offer aggressive treatment to patients with advanced COPD, the outcome is going to be very poor. And imagine if our patients, if we have to choose between 6 months of living comfortably around people he loves in his own house, in his own bed, versus in and out of hospital, in and out of ICU for a condition that is incurable. So coming to how you will evaluate a patient with any respiratory problem, all of you know this about history taking, clinical examination. I don't need to focus on the investigation list. But the two investigations which are important, which often get missed, are pulmonary function test and arterial blood gas. And parallelly, Pallium India is also having we have started a session of teaching palliative care physicians more details of respiratory medicine so that they're equipped to look after patients at home. So we are looking into the fact that lung function and ABG is not taught very well in MBBS level. So we would like to emphasize that these are two very important investigations which you should ask for a patient who is having respiratory symptoms. Now, when we train for MBBS, and as well as the fact when I trained for MD, whenever we were asked to see patients or follow up patients in OPD or inpatient, we were never trained to ask these questions. We were focusing so much on the physical aspects of breathlessness, cough, is the breathlessness better? Are you able to walk? Are you able to sleep? We never went beyond this. And you need to realize A patient who is breathless every single minute, hour after hour, day after day, week after week, year after year, must be going through so much in his head. So I would like you all, if you're able to, just sit up straight on your chairs, take a deep breath in, breathe out half. Okay? Breathe half. Take another breath from that half expirated breath. Breathe again. And just imagine that's how our patients feel every single minute and second of their lives. So if you are able to do it, if you're in the comfort, if you're sitting alone and you're able to do it, just try and experience the breathlessness that our patients face in advanced lung diseases. These patients are therefore frustrated. They have a loss of role. They are not independent anymore. They need somebody to take them to the toilet, somebody to shower them, somebody to change them. Imagine how irritating, angry, frustrating this is, and therefore constantly anxious and irritable. So these are the issues we really need to focus on, and we need to elicit in our history taking. Very often we say, are you breathless? Or is your breathlessness better? So we ask them closed questions. We need to ask them open-ended questions saying, how are you today? Or what have you stopped doing because of your breathlessness? So very often this is what opens the Pandora's box, that the patient says, I have stopped going for a walk, I'm not meeting my friends, he's socially isolated, cannot play with my grandchild, cannot do gardening, have stopped going for my drives, or whatever it is. So when you frame the question in this way, what are you avoiding to do because of to prevent worsening breathlessness? That is which will yield you very different answers and will bring out all the frustration in the patient. Any questions? Are you okay so far? Should I go on? Should I repeat something? Carry on. Okay. So that brings us to the breathing, thinking, and functioning model. And what is the breathing, thinking, and functioning model? Uh, so if you, like I said, our patient, you have to imagine sitting in a room, sitting with the oxygen, housebound, bedbound, socially isolated, dependent on caregivers, patients with patients belonging to lower middle class or lower socioeconomic, even the family members have to stop going to work because this patient needs 24/7 caregiving. Such a breathless patient, when he decides to do some activity, going to the bathroom or brushing his teeth, he gets more breathless, and that breathlessness sets off anxiety. Oh God, am I going to die? Or panic. So there is a physical state. He's breathless because of his advanced lung disease. Mentally, he's panicking because he's breathless. Because he's breathless and he's anxious, he says, oh God, yesterday I walked to the toilet and I became breathless. So let me not walk to the toilet. Let me insist on a bedside commode or a diaper. So he does less and less physical activity. And as you know, the human body, the less you use it, you will lose it. So if you do not use the muscles, you will lose the muscles. So slowly the patient gets deconditioned. So he is able to do even less and less. And he gets caught in this vicious cycle of breathing, thinking, and functioning. So the whole purpose of palliative care integration is to break this vicious cycle. We are not able to cure the COPD, surely, but the pulmonologist can focus on maximum medications to improve the pathophysiology of the condition by giving him bronchodilators, steroids, nebulizers, etc. But in order to not make him anxious, we have a psychologist to interfere. So give him relaxation techniques, counsel him, address his anxiety, fears, ask him what he really wants, teach him the techniques of relaxing and letting go of certain thoughts and acknowledging that it is a distressing situation. And in order to help him become a little more independent, introduce a physiotherapist who will give him graded exercises so that he's able to do activities of daily living with less dependence and with less effort and not get so out of breath. So the important here is the beauty of palliative care is the multidisciplinary team. So that the patient has cover on various levels and there's a safety net and patient is not therefore lost to follow up. Patient will be looked after by today is a bad day, the psychologist is there, the physiotherapist is there. So he's not isolated in his own house in one room and not even seeing the rest of the world. So breathing, thinking, functioning model actually explains why it is important to integrate multidisciplinary palliative care in respiratory medicine. Okay. So going ahead, this brings us to what is the definition of chronic breathlessness syndrome, which all our patients with advanced lung diseases as well as certain non-lung diseases like MND, like congestive cardiac failure, CKD experience. So what is the definition to understand chronic breathlessness? These are patients who are already on optimum treatment for their underlying pathophysiology, whether it's the kidney, whether it's the heart, whether it's motor neuron, they're getting everything. They still continue to be breathless at rest or minimal activity, and that affects their psychosocial, spiritual, emotional life. And when a patient is constantly breathless like this, it directly contributes to very poor quality life, very high anxiety levels, and these patients need the integration and care of a palliative care team. So this is chronic breathlessness syndrome. Now, when we have to deal with patients with chronic breathlessness, a lot of non-pharmacology has to be is very, very important. It also helps caregivers feel a role in looking after their loved ones. So simple things like positioning the patient. Some like to sit up with propped up. Some like right lateral. Some like left lateral. Some like to sit with 45 degrees. So comfortable positioning. When a patient gets into extreme breathlessness, positioning is important. Loose clothes, sitting next to a window, not in a crowded room. And one of the things that has proven in literature is handheld battery operated fan. So blow cold air or battery operated air into the patient's face. We were not able to do this during the COVID pandemic because of aerosolization, but in non-COVID patients, it has been proved that this really decreases the sensation of breathlessness. Along with this, some massage, distracting the patient, pet therapy, music therapy, relaxation techniques, certain techniques to breathe and with a purse lip. Like when you make a purse lip, you create a pressure difference between the alveoli and the lip, and therefore there is more better expiration of air, and therefore the patient can take the next breath, which is much better. And we then teach the patient to plan, prioritize and pace his work. For example, suppose he wants to go down for a walk. You tell him, don't walk down, go in a wheelchair and then walk in the garden in with 2-3 steps. So, help him adjust to whatever lung function he has. So, non-pharmacological methods of managing breathlessness is very, very important, and it is something that caregivers can learn easily and be of help to the patient. Then coming to pharmacology, I don't need to teach doctors about medications. You all know about this, that for an airway disease, you have nebulizers, bronchodilators, steroids, antibiotics, etc. And obviously, if there's an infection, we give antibiotics. If it's interstitial lung disease, there's also a role of antifibrotics. But today, what I'm going to focus on is two things. One is oxygen and two is morphine. Oxygen is a drug, please remember, and also should be administered only when indicated. Oxygen should not be given to all patients who are breathless. Oxygen should be given to patients who are breathless and their saturation is below 88. Because if you see the oxygen dissociation curve, it's below 88 when the saturation of oxygenated blood drops suddenly, which is dangerous for the cardiac health of the patient. So only if the oxygen saturation is below 88, you should stick the patient on oxygen. Otherwise, the nascent free radicals of oxygen will damage the lung. So unnecessary giving oxygen is also not good. We saw this during the COVID, the abuse of oxygen, and ended up losing patients who did not get oxygen when they needed the most, because patients who did not need oxygen also got oxygen. So please administer oxygen only between 80, when the oxygen levels are below 88. Second thing is morphine. Now, morphine is a narcotic. You all know that morphine is used widely or should be used widely in the excruciating pain of cancer. But in very low doses, we use effectively for treating chronic breathlessness. And please remember that it doesn't worsen hypoxia, it doesn't worsen the type 2 respiratory failure, it decreases the work of breathing because it's centrally acting, it decreases the respiratory rate, it improves the tidal respiration, and it makes the patient less breathless. So, for the past 4 years, I've had so many patients of COPD and interstitial lung disease who come to the clinic in a wheelchair, and the next follow up on morphine are able to dress up nicely and come walking from the gate to the clinic. So we are not able to change the outcome or the change the anatomy of the lung, but at least we are helping them improve their quality of life, making them enjoy doing small things, talking on the phone, taking a bath on their own, eating meals with the family, small pleasures of life we are able to uh, provide. And that is the whole meaning, right? We have to improve the quality of life of patients, and we focus too much on the quantity of life. And that is where our thought process needs to change. How do we start opioid? 2 point, if a patient is eating orally, we give 2.5 milligrams twice a day along with laxatives, because smallest dose of morphine also causes constipation. We cannot afford a patient of breathlessness to be constipated. It's a recipe for disaster. So small dose of morphine, 2.5 twice a day, gradually titrated weekly with 25% increase. If you feel that the patient is anxious, you can add benzodiazepine medium acting. And if the patient is in panic attack, we add longer acting benzodiazepines. So it's important to improve the quality of life of patients and not let him suffer that breathlessness. Please also remember, along with morphine, all his underlying medications for his pathophysiology should and must continue. So you cannot only give morphine and forget about oxygen or forget about bronchodilators or nebulizers or steroids. Morphine only reduces the sensation of breathlessness and makes the patient more comfortable. Okay, it is a safe drug when used in these doses. It's highly effective, and what it does magically is improves the patient's quality of life. Of course, there'll be patients who do not improve with morphine. That is why you need to review the patients closely, follow them up, and those patients who do not benefit from morphine should not be continued on morphine, because what's the point of giving if the patient is not going to benefit? You should see a response within the first 2 days itself to see whether you can continue the use of morphine. Any questions or thoughts? Anything on the chat? Nothing yet. So I'll continue. Morphine also, another thing that you all need to learn is, hear about, is terminal breathlessness, which is what is experienced by a lot of our patients, irrespective of the cause. We see the breathlessness is common even in cancer, CCF, stroke with aspiration, Parkinson's with aspiration. All these patients can experience terminal breathlessness. And you also must have heard of the famous quote of Dame Cicely Saunders, where the manner in which your loved one dies is etched in memory of those who live on. So, not just for the comfort of the patient, but for the physical and mental comfort of the caregivers, it's very important that patients are comfortable during their active phase of dying and they transition from life to death in peace. It is our responsibility, because we know that this patient is not going to survive and lead a good, meaningful, quality life. It is our onus to see to that the patient at least transition in peace. And that's where terminal breathlessness comes in, and what we call as palliative sedation, where the intent is comfort, the intent is that patient is not struggling to breathe. And that's the time we use a combination of morphine and midazolam in a syringe pump given subcutaneously over 24 hours. If the patient is agitated, we also add haloperidol. So this is given in a tiny dose The intent being comfortable and intent being that the patient transitions in peace, obviously after a detailed communication with the patient and the caregivers, explaining to them that the patient will be unresponsive and explaining to them and taking their consent about why we are doing palliative sedation. Anything, anybody wants to ask something now, or shall I go ahead? Because this is a concept which may be new to some people. Oral morphine parul we give in the dose of 2.5 milligrams twice a day and gradually increase it. We never need to go beyond 30 milligrams for breathlessness. Most patients are comfortable within the 20 milligrams. Because in Bombay, we do not get sustained release, we use immediate release. So we eventually do manage to give the patient, say, 2.5 every 4 hours or alternated 2.55 depending on the patient's requirement. Okay. So I'll go on to the other symptoms which we commonly see in respiratory diseases, which is cough, pleural effusion, hemoptysis, and a little bit on hiccups. So cough, yes, is a protective reflex, but when it becomes persistent, it can be very irritating and it can be extremely disturbing for the patient. Yes, somebody has said, is it legal to give palliative sedation? So Dr. Indra, like I told you, according to medical ethics, you obviously have the consent of the patient, which is autonomy. You're doing it in the best interest of the patient, not causing harm. Everything has been discussed, documented. Idea is to aggressively treat the symptoms of the patient. Idea is not to end life. Ending life is the doctrine of double effect of the palliative sedation. So please remember, you are treating terminal breathlessness. You are not killing the patient. So this is not where you give a lethal dose of morphine and the patient dies the next minute. When you give palliative sedation, it takes 24 to 48 hours sometimes for the patient to die. And the idea is that that few hours of active dying, the patient is comfortable. So there's nothing illegal about it. It is in the best interest of the patient. It is basically keeping the patient comfortable. Does that satisfy you, your question? So let me go on with cough. So cough, you also must be, thank you. You also must realize that cough is not only produced because of a lung problem. It could be lung, it could be heart, it could be ENT, it could be upper respiratory tract, GI, certain medication, certain treatment, as well as psychogenic. So please, again, history taking, very, very important. And that will lead you to where this cough is coming from. So once you know if the cough is because of respiratory, you go back to what the diagnosis is and optimally make the patient take all the medications. For example, inhalers, for example, lifestyle for GERD, for example, diuretics in congestive cardiac failure. So all these things are very, very important. Suppose the patient has a cough which is due to radiation, then steroids makes a difference. Suppose you have realized that the patient has a psychogenic cough, especially in children, then the patient definitely needs counseling and psychiatry. But intractable, irritating cough that could probably seen in, say, patients with advanced COPD or advanced interstitial lung disease, there are certain things we do. Again, non-pharmacological is important, like hot water, ginger, there's some pressure point, acupressure point that can help the patient with reduce the cough. Then you can also start with the patient, for example, codeine, which is a weak opioid. So we start with codeine syrup. Morphine helps in decreasing the cough. And if patients are still continuing to cough, sometimes even gabapentin has been seen to be useful in patients with intractable cough. Then comes to pleural effusion, which very often is seen in patients with uh, metastatic metastatic cancers from the lung, breast, ovary, etc. It can be very distressing, and the patient can be having breathlessness because of ventilation perfusion mismatch. The way we manage, or the palliative care management of pleural effusion, directly depends on the prognosis of the patient. So if the prognosis of the patient is good, that is the cancer, if the patient is going to live for more than a month, we then put the patient on a pigtail catheter. which is inserted into the intercostal space and slowly drains the fluid. So patient doesn't have to get acutely breathless, rush to hospital, tap the fluid. No such drama. But if the patient is not got a good prognosis, just to relieve the patient and make him comfortable, we then aspirate one time and send the patient home. But for the breathlessness, you can still try the morphine so patient is comfortable. If the patient's prognosis is good, we also attempt what we call as pleurodesis. And what is pleurodesis? Pleurodesis is a condition where we obliterate the space, potential space between the parietal and the visceral pleura. So once we drain the fluid, we then put inflammatory agents like bleomycin or talc, sterile talc, and create intense inflammation in the two layers of the pleura, and so that they both fuse. So it's like there's no space for the fluid to fill. That is some things we do if the patient's prognosis is good, and it's important if we are able to drain the fluid completely and approximate the two layers of the pleura. Then, of course, hemoptysis, very important. There are certain situations like buccal, hemorrhage from the lung is obviously hemoptysis. So when you expect a person to bleed, for example, a tumor sitting on the carotid, tumor sitting on a main vessel, you should prepare the patient and the family that this could happen. And also what they should do in an emergency, because this is very difficult to manage at home with blood spluttering at all sides. Give them the contact numbers, because management of hemoptysis is usually done in a tertiary level center, because we do laser, cryo, bronchial artery embolization. These things are a little complicated, but these are palliative measures to control the bleeding. And you must remember that when a patient has hemoptysis, it's not the blood loss that kills the patient. Very often patient aspirates his own blood and he drowns in his blood, and that is what causes the death. So we really need to prevent the aspiration and stop the bleeding, but this requires much more sophisticated techniques, and patients should be sent home with details of where he can get these procedures done so that they can rush to that particular hospital even in the middle of night. Okay, so very, very important. And very often what we do is put a flexible bronchoscope through the rigid bronchoscope and inject tranexamic acid or adrenaline to stop the bleeding. We can also give the patient injectable tranexamic acid to stop the bleeding after we've done the procedure. Just a small note on the pandemic and the palliative care. I think COVID pandemic brought death and dying into sharp focus. We have been focusing on chronic illnesses and palliative care, but COVID taught us that even an acute illness like the COVID really needed the importance of palliative care, because patients were alone in the hospital, family was somewhere else. Well, patients were suddenly dying. That had to be communicated to the family. Certain important decisions had to be made. Certain families lost more than one family member. So it was a situation of acute humanitarian crisis. And I think if India had more training with palliative care, we would have handled the pandemic at a different level. So it's very important for us to realize that in such situations, it is even more important to have knowledge of pandemic care, of palliative care. Select patients appropriately for the ICU, because we don't have the resources to admit all patients and ventilate all patients. Second thing, even elderly, we saw how in Italy, in US, elderly people succumbed to COVID. For such patients, we should ideally have asked them their wishes even before admitting them to the hospital, for which we needed palliative care training. Sorry, there's one question by Roshan Kumar Patil. How to tackle breathlessness in metastatic patients, florid lung mets, when there is no or minimal PE. So it could be lymphangitis carcinomatosis, for which we use steroids. So we need to follow everything possible. For example, we give steroids, we give nebulizer. If the patient is acute bronchospasm, we treat the patient with oxygen. Even after all that, the patient continues to have, morphine will work very well, even in metastatic lung mets. So COVID patients, very important time for thinking of medical ethics, triaging the patients, proper selection. Those patients doing poorly despite maximum medical treatment, we need to shift them to comfort care, and communication, which was so vital during the pandemic, through WhatsApp, through video calls, through Zoom calls, because patients and caregivers were not together. So also in the ICU, We did a lot of withholding and withdrawing of care, especially when patients were 80 plus, 90 plus, comorbidities, not doing well. We actually sat and talked to the relatives that please don't put him on the ventilator, let's give him comfort care. Or patients who were doing poorly with maximum, we actually withdrew them from ventilators because we also needed that patient to be comfortable and important for dignity, respect, and comfort for all our patients. I'm going to stop there because Andrew has asked a question of role of steam inhalation. Can you explain, Andrew, in what situation is steam inhalation you want to talk about? And then I can answer that. And again, we have now seen patients post-COVID with fibrosis requiring, and COVID itself, the isolation, separation from family, causing a lot of mental health issues and therefore requiring a lot of, hand holding, counseling, physiotherapy. So a lot of palliative care even in post-COVID. This is what we are seeing for post-COVID fibrosis. 1/3 of the patient actually deteriorate, 1/3 improve, and 1/3 remain the same. So the last thing I really want to tell you is that irrespective of the patient's condition, the needs of the people are the same at the end of life. Whether it's cancer, elderly, dementia, Parkinson's, COPD, everything, the needs of these patients are the same. So which is why palliative care is need-based. Therefore, palliative care has a role in every chronic illness or in every illness. And this is very important for us to remember that we die only once and we need to live to the full capacity every day, like there is no tomorrow. So that is very, very important for us to remember. With that, I'll stop sharing. And there is some questions which I'll ask before we go to the, are we okay time wise?
Yes, ma'am. Perfect.
Legal, metastatic, steam. So steam inhalation, has a role, especially in patients with copious amount of secretions, thick secretions, not able to bring it out, etc. Or in certain upper respiratory tract infection, when there's a lot of congestion, where there's sinus congestion, the patient feels heavy, etc. So it's again something that you should advise if the patient feels comfortable. It's not something that you should. Some patients feel that their secretions dry up or that irritates them and it causes cough. So if patients are not comfortable with steam, it's not something that will help everybody. Let them try steam, let them try hot water gargles. If it benefits them, yes, they should do it. It's like saying, for example, some people like to do deep tissue massage, they love it. And there are some people who hate it when people do massage. It's not that massage is bad, it is to each his own. So try the steam if it works well, but usually it is should be given when patients have congestion or a lot of copious amount of secretions. So that is on steam. There was another question on some methylene blue. Uh, SpO2, there's no connection with SpO2 and steam. And remember that if the patient has a saturation of 90, please try other things before you stick oxygen to him. Anxiety can be a big cause. So distract him, positioning, handheld fan, talk to him, all those things work better than oxygen. You're just unnecessarily making the lungs more succumb to the nascent free radical. Thank you, Dr. Sumita and Parul and Indra. For how long can we use steroids in patients with lymphangitis? So in this way we use it is for comfort, because lymphangitis carcinomatosis is a terminal event. So, we don't have to worry about side effects, problems with steroids. We need the patient comfortable. So there's no duration. The patient has to be comfortable. Proper hydration helps it absolutely. So there are simple things like drink enough water. Very, very important to make the secretions thin, so that patient can easily expectorate it, and patient can be just given physiotherapy by gravity to remove the secretions if the secretions are thin. Any more questions? Thanks, Manisha. Even working in a tertiary center, Roshan Kumar has commented, it is difficult to send non-meds patients with advanced cancer and with severe breathlessness to palliative care when we are treating him her to curative intent. How to deal with it? So, who is we are treating her with the curative intent? That is important. For example, one of the pillars of medical ethics is autonomy. So we all need to get into this habit of telling the patient the full clinical picture in a language that he or she understands. Once you describe the situation कि आपका कैंसर फैल गया है, इधर चला गया है, लिवर पे चला गया है, bone marrow, all that. Even if I treat it, it is only this much percent chance. Let him decide, na, what he wants to do. What is the point of who are we to tell, try this, try that, it will save you? The person is going to endure that treatment. If the person is already miserable with his metastatic disease, do you think sometimes the treatment makes the condition worse than the illness itself? Ask him what he wants to do. Spend the rest of his life in and out of hospitals or be at home. So this whole thing of patient centered, person centered decision is important. We should help the patient make decisions. We should not be deciding for the patient. Take immunotherapy. Take this. This is new drug which has come in America. Try this also. He will become bankrupt doing all that. Because see, everybody loves to hold on to dear life. You and me should be able to tell them clearly what is the effects of those drugs. How is his life going to improve? Is he going to live 10 more days with in agony or 10 more days with good quality life? That is what is important, right? Today, you and me, touch wood, are in fairly good health. It's very difficult to imagine how it is to be in poor health. For example, suppose you have fractured your leg, fractured your arm, even those 2, 3 weeks when somebody is combing your hair, somebody is changing you, wiping your back, it is disgusting. You do not like it. It is against dignity. And any chronic illness strips you of this dignity. We should be giving patients their dignity back, even if they're in a vulnerable, helpless situation. Like if you've looked after a parent or a grandparent who's not able to turn, who's not able to get up, it's heartbreaking to see your loved one like that. And uspe also we as doctors say, try this also, try this also. There needs to be a line of letting go. We all need to realize, why did we become doctors? To cure illnesses, to overcome death. What did we become doctors for? To alleviate suffering. Are we doing that in our daily jobs? Are we feel cured patient. Like I know when I did my MD, I used to say, मेरे duty पे patient मरना नहीं चाहिए. It's not in my hands, right? You should be able to do your 100% best for the patient and not just for the patient's physical health. It has to be for his emotional health. How often I have never done it. I'm being very honest. In ICU for a dying patient, I have never stood there holding his hand saying, घबराओ मत, आपको किसी को बुलाना है क्या? Do you want to talk to your daughter? I have only been saying, get adrenaline, do CPR, get DC shock. It's a patient for me, not a human being. We need to change that approach. We need to make compassionate, kind doctors. So this whole concept of curative intent, see, everybody wants to be cured and everybody wants to live forever. That's not going to happen. We need to put things in perspective and therefore integrate palliative care so that the patient is able to decide sensibly. I'm not sure whether I gave a big bhashan for this, Roshan Kumar, and are you satisfied with it? But it cannot be your decision. It should not be. It should be the patient's decision. And for the patient to decide, you have to lay all the cards in front of him and support him in whatever decisions he take. Not that मैंने बोला था ना, ये नहीं करना चाहिए था. That is not your thing to say. I told you so is the worst thing for any doctor to say. He decides, fine. Everybody is not going to be the same. But the point is, your support is irrespective of his decision. And your support is promised to him at whatever path he chooses to take. So it is important, and this is where communication skills comes in. The most difficult things are sorted by narrative medicine, and good communication is like doing a procedure or an appendectomy which looks classic. If you talk well, effectively, and you manage to communicate effectively, it is like really doing an excellent procedure. That's why we also call palliative care as narrative medicine. It is like a procedure from complete denial, how the patient slowly accepts the situation and then is able to decide without getting flustered, without getting emotional. It is a beauty that you need to see. Thank you, Dr. Shivani. Roshan, was that helpful to you or?
Yes, ma'am. I
Thank you,
was just
Dr.
talking about
Patel.
the palliative stamp. I mean, when the patient has been giving like a stamp of palliative services,
Yeah.
then patient realizes ki, why should I go to palliative? I mean, sometimes
No,
the
no, 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 no.
affected
That is
patients
how that is
moves
how the hospital consultants puts it. So there's a
yeah,
lot of debate in the palliative care world about calling it palliative. They say it's a very got a negative connotation, but you use your own terms. So for example, my colleagues say, uh, why don't you go to my colleague who will help you and support you to improve your quality of life, or go to our supportive care consultant. You don't have to call it palliative care. So you use the point is the way hospital consultants portray it. It's almost like mera kaam ho gaya abhi palliative. That should not be the point. It's not that you're abandoning your patient. It has to be a smooth transition. So the way my respiratory colleagues introduce me is, I want to introduce you to another part of my team member who will focus on your quality of life. Why don't you share your apprehensions, fears, anxiety with her and see how she and me will improve your quality of life? Instead of saying, my role is over, now you go to her and die. That's not the point. The way you say things makes a difference. So it has to be, if you say, now go to palliative care, the patient says, but saab, I have come to you for the past 5 years. Now why are you sending me? That itself is going to upset the patient. So that's why it has to be integrated and the transition has to be smooth. False hope, sorry, that's what I missed. Attitude increases, patients false hope, and they will be served at all costs. Yeah. So it's very true. We also, do you realize that medicine is one profession closest to human suffering due to health? Medicine is one profession where death is something that we see almost daily. Yet it is a training. When you and me went to med school, nobody taught us how to talk. Nobody taught us how to talk about death and dying. We ourselves are uncomfortable saying the word death. We ourselves have not thought of our own mortality. We ourselves, therefore, are not comfortable talking with patients कि आपका disease ये है, आप इतने दिन जियोगे, या this is how it's going to be. We avoid using the word D. Am I right or am I wrong? Isn't it true that we are uncomfortable talking about it? So we need to change this. And I think COVID has managed to change it a little bit, because good people walked into casualty and just died. And you realize how fragile life was. But that is how it is. We can't overcome death. But so death is inevitable, but a bad death is avoidable. We can avoid a lot of ICU admissions. Today, also, I see 96-year-olds going to ICU for aspiration pneumonia. How are we going to make this patient live till 120? We are not. Instead, the way the corporate hospitals look at it is, this is the last time to make money out of the 96-year-olds. There's a joke that in corporate hospitals, the rich cannot come out and the poor cannot go in. Because एक बकरा आया तो छोड़ने का नहीं, सब कुछ करके छोड़ने का. Point is goodwill. If this man didn't become 96 overnight, he's becoming 96 for 96 years. So automatically it becomes the onus of the family physician. Your father is now 90. Have you asked him what he wants to do when he's going to be ill? Does he want to get admitted in hospital? These conversations need to start. Because when do they think of these conversations? When the patient has had a fall, patient has had a stroke, or the patient is aspirated, suddenly there'll be a call. Now what to do? Now what to do? That's the wrongest time to talk. Because I'll ask you a question. When is a good time to swim? During a storm or when the sea is calm? When would you like to learn to swim? Obviously, when the sea is calm. But when everything is calm, we think that death is going to come only to neighbor's house, not to my house. So we need to change our attitude. We need to talk about death and dying. And now there's a beautiful few slides. I'm happy to share those slides also if permission of Pallium India. I don't want to go overboard. About the Queen's death. I know the BBC and all the channels are like only talking about it. Maybe you're already bored about it. But let me just share those. 1 minute. Can you see?
Not yet, ma'am.
1 minute. Huh? One second. I don't know what I'm doing here. Sorry, bear with me.
Yes, ma'am.
So this is some of the things that she has put up, which it makes a lot of sense. And she was 96 when she died. And what has it taught us about dying? So this is very, very true that she showed the world the process of ordinary dying. She still came in public 2 days before she died with a stick and all, but the dignity with which she died, quietly. If she's a queen, she could have brought the whole world to its knees. But process of dying went unspoken, unnamed. Quietly, she just disappeared into it. It's time we learn to talk about death and dying. And very, very important. These are small things, but for people who have lost a loved one, if the loved one has passed away in peace, in comfort, it's a matter of great consolation and even the bereavement. So you think of the person, of course, you will miss the person, and of course, you will get tears to your eyes, but at least you feel that the person didn't suffer. Instead of tubes in every orifice, I don't know any of us who know people who pray in front of the Lord saying, please keep me alive at any cost, with tubes in every orifice, in the ICU, alone. I want to die like that. Do you know of any human being? Can you think of any human being? Yet our ICUs are full. We never ask our patients what they want. ICUs are very important. I'm not denying it, but they are meant for people who can be salvaged and brought back to life to original quality of life. Not tottering, not poor quality life. Very, very important. Sorry, I've taken more than what time I should. So we can go to the case presentation because it's already 4:05, and I'm sure you'll have other things, more important things to get to after this.
Dr. Mrena?
Yeah. Hello. I'm audible, no? Hello.
Yes, audible, sir.
Acha, good afternoon, ma'am, and all the participants. I'm Dr. Minal Dev Chaudhary. Right now, I'm a fellow in State Cancer Institute. Acha, my case is a 25-year-old young guy, male, who had diagnosis of thymic clear cell carcinoma in anterior mediastinum. So he presented in our hospital OPD with complaints of breathing difficulty since 2 to 3 days, difficulty in swallowing since 2 to 3 days. He had a dry cough since 1 month, a bilateral lower extremity swelling, and heaviness in chest. So at first, the patient was having complaints of dry cough since 1 month, since 2 to 3 weeks, but he was not taking medication or any advice from any doctors in OPD or anywhere. He was taking some cough syrup or something, which usually most of the people do from any pharmacy or something like that. When he did not get relief of the cough, after that he consulted some doctors and they advised him a X-ray, which showed a mediastinal mass. So the doctor referred him to GMC hospital, government hospital, because the patient is the only one young guy but not earning very good. So he referred him to the government hospital where a CT thorax was done, which showed the mass, mediastinal mass, and a biopsy was also done. So in the biopsy, it was diagnosed as thymic clear cell carcinoma, and then the patient was again referred back to the State Cancer Institute for all carcinoma managements. So at that time, the patient breathing difficulty and swallowing and were little increased. He was not able to breathe nicely. It was very difficult for him to swallow solid solid foods, and he had very recurrent cough. So he presented in our OPD, and I remember that when that day when he presented in our OPD with his mother was literally crying and was like begging us so to save his son because he was not able to breathe. Second, next slide, please. Acha, on examination, we found that his SpO2 level was nearby 93-94% in room air. There was very chest bilateral wheezing was there. Most of the vitals rest were all okay. So we admitted the patient. Yeah, next slide, please. So we admitted the patients and started nebulization with beta agonist, injectable dexamethasone, and morphine. Also, I have started for him a 2.5 mg dose, but I did it in TDS manner, 3 times a day, and I uh, I consulted some other seniors in my department and medical oncologist also. So after the investigations which we got, most of his blood parameters were around the normal range. But and in CT we already got the mediastinal mass, and the biopsy also confirmed it. Next slide, please. So the psychological aspects was that the 25-year unmarried young male living with parents in a stable job, he's he's the only bread earner in his family at not working for this 2 to 3 weeks because of his condition. He his father was a disabled person because he lost his one leg like 2 years ago to some accident. Mother was not working, she was a housewife, and she was not literate also, and till his symptoms appear he was working, but after he could not breathe nicely or eat anything, he stopped working. He and his later on in the few stages, he and his mother knew about the disease, but mother tries not to break down in front of him, and he also tries to keep himself calm joyfully at the time. Mother looks very confused because she was trying that whatever can be done, she was ready to do. She was again asking us if the treatment can be possible here, or she wants to take him outside for better treatment, whatever is available. although they were very financially very not well to do, but still uh, they wanted to do it. Next slide, please. So all this medication was started from medical oncology, started this paclitaxel, carboplatin, AUC6 regimens. From our side palliative department, we gave him this derifilin, nebulization was done, some cough syrup and multivitamins. On the first day when this chemotherapy was started, nobody was sure that it will work from him, but he got little bit relief from his distress. So main concerns were when we started this chemotherapy, we sent the patient home. So main concerns are respiratory failure that can even happen when in his hometown or in a home, dysphagia, and the financial issue. So the summary: 25-year-old male diagnosed with thymic clear cell carcinoma is on paclitaxel and carboplatin EU6 with other supportive medications. I want to discuss this point, that treatment modalities that he may need further and how to tackle that situation at home basis. Things that should be present in his first aid kit that the mother or he himself can use at the time if anything happens, and what can be done for the family so that they will be relieved of this financial burden. I want to add something about the financial burden, that we have started something that after submitting this case discussion, I saw some groups in online some groups who contribute like financial, they give financial aid to the patients who are poor and poor or can't afford the treatment. So this is my case presentation today. No, surgical debulking was not it's not feasible because it's in the anterior mediastinum and the size is progressively very increasing. I remember the first day when he came to us. At that time, we consulted as surgical oncologist also, and according to them, it will be a very difficult situation. And in other cases also, like if you see anywhere, there are no indication for surgical intervention in thymic clear cells because you don't get the clear cut margins or anything.
But what about the prognosis of the clear cell?
Ma'am,
What is the
as the
survival rate?
medical
How aggressive is it?
cervical rate is it's very aggressive disease. Uh, I understand that we referred the patient once to radiation oncologist also, and they planned for radiation. In 1 week, the patient tumor size increased to 20%. So they planned for radiation, but after seeing that the progressiveness of the tumor, they deferred it.
So this is very sad on many accounts, right? First of all, the worst thing is to have bury a child. It's the worst thing that anybody can go through. And plus financially they're bad. Plus the father is already a disabled. Plus there is nobody else to earn the money. Plus there are no other children. He was only child. So in
No,
that sense, I
yeah.
think counseling takes first because this grief is really, really much. And yes, somebody has commented of palliative radio. Did you try that?
Yeah, we tried that, but due to the progressive disease and increasing size, they are deferring it. They said that it will be of no help and can't be done.
Okay, fine. So another
Yeah,
thing, so
and
did you have a chance to involve psychology, counseling, etc.?
Yeah, we have involved the mother first.
Hmm.
The psychologists, they counsel the mother. She, whenever you counsel her or talk to her, she shows that she understood the situation.
Hmm.
But whenever she sees that we are giving a visit to the patient or anything, always she asks us that if anything can be done more.
But that is natural, right? That whole
Yeah,
process,
yeah,
you've heard
ma'am.
of that Kubler-Ross cycle of acceptance. It is not going to be easy. It has to be constant reiteration. And even though she sees him deteriorating, she will not accept that he's deteriorating. So it's very difficult. That has to be an ongoing thing for the mother, even after losing the son, because a bereavement can be very, very complicated. And your question
Yeah,
about treatment modalities, yeah. So I think these are the things that the oncologist actually can decide. But when it comes from a palliative care side, you need to focus on comfort. So pain, breathlessness, appetite, mood, anxiety, those kind of things is something that we should address and we should look for. We need to train our minds to go beyond physical symptoms and ask, is him coping okay? What are their anxieties? What are their fears? Is there something you would like to eat? Is there somebody you would like to meet? Those kind of things, so that we actually try and make him happy in the given circumstances. And the financial burden, so you yourself have asked the solution, and Pallium I think does a lot to rehabilitate families who have lost the breadwinners, how to keep them engaged, how to make them earn money, etc. So I think Pallium will be the best person to answer that. And things in the first aid kit. So this hospital that this patient was a government hospital.
yeah, it's government hospital, ma'am.
Okay. So then in the first, I mean, then at least they can come back to the hospital for casualty. But the typical kind of patients, when we know are terminal and they're sitting at home, then we do see to it that they have their prescriptions and the family GP with morphine, with midazolam, with haloperidol, substitute oxygen, those kind of things. Sometimes patients with hospital bed, air mattress, those are the kind of first aid kit we keep. So we give what is called as an anticipatory prescription. So depending on the patient's condition, we expect him to say have vomiting or itching or hallucinations or agitated behavior. So depending on the anticipatory prescription, we give a list of medications that they should keep. We talk to the family GP so that the family GP knows the indication of which medication to use, when, and how much and how to give. So that is what the conversation we have in a family meeting, as that is called as an anticipatory prescription list. But I think the biggest role here is one, comfort for the patient in every way, and the mother to accept the loss of her only child. That is what is the sad part, because the cancer is extremely aggressive and there's really nothing you can do to cure this child.
Right, ma'am.
Any other thoughts or comments? I might have missed something. Anybody else wants to share? Any comments? Somebody has commented. Palliative radiation, intent radical radiation will definitely help with anti-edema measures to relieve breathlessness. Point noted, uh, Roshan Kumar. Does that help you, Mrinal?
No, it doesn't help, ma'am, because the breathlessness and this the dysphagia is due to the mass that is increased in his
Pressure
medulla.
effect.
Yeah.
Morphine will help.
So
You can try
yeah,
morphine.
more we
You
have
had
given
tried, right?
2.5 mg. Yeah,
Yeah.
2.5 mg we have started, and radiation doesn't decrease the thymic clear cell. This one because it is not at all useful in thymic clear cells.
Okay. Anything else? Any more points? Any questions? Any queries, thoughts? We can stop sharing the slides and go back to the, yeah. Anybody wants to make a comment or anything?
Dr. Urmila suggested positioning of the patient.
Sorry?
Positioning of the patient, Dr. Urmila has pointed out. She says,
Yeah, but I think it's also something that is pressure, the mass effect, that is difficult to go away with the positioning. I think morphine, did the morphine help, Dr. Mrinal?
Yeah, morphine to some extent helps.
Because it's a centrally acting thing, it decreases the sensation of breathlessness. But I can imagine it being quite distressing. The whole situation is distressing, not just the physical mass.
Yeah. Yeah, he doesn't complain of any pain or anything, but always there that something heaviness is in their chest.
Sure, mother can be helped by involving local NGOs if she's able to stitch. Yeah, that's to rehabilitate. Yeah, that's true. And I think, like I said, Pallium does a lot of it. So no more questions, no more queries. Everybody is itching for that cup of tea, so I'll let them go. It is chai time now. So thank you for your participation, and please do share those two documents with everybody, the gold standard framework and the blue maple, because it will be extremely beneficial. And good luck to all of you. Have a good evening and please stay safe. Bye.
Thank you, Dr. Rajam, for joining us. We do know your schedule. You are so busy. Yesterday also we troubled you during late night for that new session, new program.
No problem. That's my pleasure. So I think that's another thing that this batch will also be interested if we conduct
Yes.
in the near future.
Yes, ma'am, definitely,
Sure.
yes.
Okay.
So thank you for your association with us, and we do look forward for more such sessions in future as well.
Sure.
So I
Thank
hope
you.
that this session was equally enlightening for everyone. So with that note, this is Sri Priya along with Dr. Rajam Iyer signing off for the day. See you tomorrow with another topic and another eminent faculty. Till then, everyone, take care. Bye bye.
Bye.